Good morning, respected teachers and my dear colleagues. Today I am going to present a case of SLA with multi-organ dysfunction. Demographic details: Mrs. SK, 30-year-old female resident of Karnal, Haryana, admitted on 3rd February 2022 and discharged on 22nd February 2022 under IM2. Her chief complaints were chest pain since 1 week, shortness of breath since 1 week, pain and swelling of the bilateral small joints of hands and feet since 1 week, bluish black discoloration of fingers and toes since 1 week. Coming to background history, in 2012 she had history of joint pains involving small joints of hands and feet associated with early morning stiffness which lasted for 30 to 45 minutes. It was relieved with activity and increased with rest. She had relief of symptoms with over-the-counter medication and the symptoms lasted for 5 months. It was associated with bluish discoloration of fingers, toes and tip of the nose on exposure to cold, and it got relieved by putting her hands in warm water. She also had recurrent of these joint symptoms in 2014 and 2017, which got relieved with over-the-counter medication, and she was not evaluated. In 2019, her joint symptoms were severe enough to hamper her activities of daily living. When she was evaluated in Italy, the available record shows she is having ANA and anti-positivity, for which she received weekly subcutaneous methotrexate and symptoms got controlled fairly. She also had bad obstetric history in the form of fetal complete heart block at 4th month of gestation in 2012, subsequently sustained intrauterine death and abortion was induced. In 2017, she also had preterm birth at 7th month of gestation age, followed by NICU stay for 3 months. Now the child is healthy and living. In 2018, she had second trimester abortion. In August 2021, she had history of shortness of breath, which was insidious in onset, gradually progressed from MMRC1 to MMRC3, not associated with orthopnea, PND, palpitation or syncopal attack, and these symptoms got relieved with MDI, and she was not evaluated. Coming to history of presenting illness, her chest pain was since 1 week, which was sudden in onset, moderate to severe in intensity, associated with retrosternal discomfort, increased with inspiration and activity, and relieved with rest. There were no postural symptoms. History of shortness of breath since 1 week, which was insidious in onset, gradually progressed from NYHA grade 2 to grade 4, worsened with activity and relieved with rest. There was also associated history of paroxysmal nocturnal dyspnea. She also had history of bluish black discoloration of fingers and toes since 1 week, associated with joint pains, which is similar in character to that in the past. There was no history of oliguria, nocturia, frothuria, hematuria, no history of pain abdomen, abdominal distension, hematemesis or hematochezia, no history of sicca symptoms, sinonasal symptoms or oral ulcers, no history of weakness of upper limb or lower limb, bowel and bladder involvement or cranial involvement, no history of headache, altermental sensory or focal neurological deficits. There is no history of diabetes, hypertension, asthma, CVA, CAD, epilepsy or past TB. There is no history of similar illness in the family. Coming to personal history, she consumes mixed diet with good appetite, sleep was adequate, bowel and bladder habits were regular, and there were no ill addictions. General physical examination, patient was conscious and oriented. Her vitals at the time of examination were pulse rate of 116 beats per minute, normal in volume, regular in rhythm, all peripheral pulses were palpable. Respiratory rate was 26 cycles per minute, saturation of 95% at room air. Her BP was 154 by 99 mm of mercury in the right arm supine position. She is having pallor, but there was no icterus, sinuses, clubbing, lymphadenopathy or edema. Musculoskeletal examination, her tender joint count was 22 out of 28 and swollen joint count was 16 out of 28. There was decreased range of movement of the affected joint and power cannot be assessed due to pain. On head-to-toe examination, she has typical malar rash with nasolabial sparing. She also had bluish discoloration of tip of the nose. She had lividite rash involving bilateral palms and soles. Bluish discoloration of tips of fingers and toes was seen, suggestive of pregangrenous changes. Coming to systemic examination, pansystolic murmur is had at the apex radiating to the axilla and interscapular area. S1 and S2 are had normally, no S3, S4 or loud P2. Per abdomen was soft, liver is palpable 3 cm below the right costal margin. Margins were regular, firm in consistency, non-tender, non-pulsatile. No evidence of free fluid. Bowel sounds were present. Bilateral air entry was equal, normal vesicular breath sounds were heard on respiratory system. In CNS, higher mental functions were intact, no focal neurological deficits. Bilateral plantar showed flexor response and deep tendon reflexes were normal. Coming to timeline of events, in 2012 she had polyarthritis, Raynaud's phenomenon, second trimester abortion and fetal complete heart block. In 2014 she had recurrence of polyarthritis. In 2017 she had history of preterm delivery, and in 2018 she had second trimester abortion. Recurrence of symptoms with NA and anti-positivity in 2019. In 2021, she had shortness of breath. Currently, she is having chest pain and shortness of breath. Coming to her investigation, at baseline, she was found to have anemia with a HB of 9.0. On workup, her MCV was 65, RDW was 22, peripheral blood film showed microcytosis and anisopoikilocytosis. Retic count was 2.75 and serum iron and ferritin was low. Overall picture was fitting into iron deficiency anemia. During the course of hospital stay, she had a drop in HB. On workup, her LDH was found to be elevated with and plasma HB was 30 mg per deciliter. PBF showed 2% schistocytes and direct antibody test was negative. We kept a possibility of ongoing hemolysis. Query microangiopathic hemolytic anemia was considered in view of background of symptoms suggestive of SLE and presence of high BP recordings. She also found her thrombocytopenia throughout the course of hospital stay, which got subsequently improved with treatment. She also found to have deranged RFT with a creatinine of 2.0. On workup, 24-hour urine protein showed 1.1 gram of protein and urine RME showed albumin of 3+ and RBC of 3+. Two possibilities were kept here, lupus nephritis and APL nephropathy. Since the patient had a history of typical Malar rash in the background along with polyarthritis and NA positivity, we kept a possibility of lupus nephritis. And however, APL nephropathy cannot be ruled out because in the background she had history of bad obstetric history along with the livedoid rash. She also had significant transaminitis throughout the hospital stay. Her autoimmune workup revealed ANA of 2+ nucleolar speckled pattern, anti-DS DNA was negative, C3, C4 were low, anti-CCP was positive with high titers, anti-Rho was positive, MP1 PR3 ANCA was negative. Lipid profile was normal. USG whole abdomen shows liver of 16 cm with normal ecotexture and surface, spleen of 9 cm with normal ecotexture, no evidence of free fluid. This is her ECG, which is showing there is, although there is no tachycardia, but there is deep S1 in lead 1 and Q3 and deep QA and T wave inversion in lead 3. Her cardiac biomarkers were elevated with a trop I of 2600 and proBNP of 16,000. Her 2D echo showed severe MR with mild PH and thickened anterior mitral leaflet and posterior mitral leaflet with restricted motion. LA and LV were dilated with normal EF. Her compression in bilateral USG lower limb showed left femoral DVT extending into the external iliac vein. Her infective workup was non-revealing. So, considering the sudden onset shortness of breath along with the presence of S1, Q3, T3 and presence of DVT in ultrasound, we did V/Q scan to look for any evidence of pulmonary thromboembolism. This is the parenchymal window which is showing normal pulmonary parenchyma. This is a superimposed SPECT image which is showing decreased tracer uptake in the left lower lobe along with decreased tracer uptake in the right lower lobe along with decreased tracer uptake in the left upper lobe. This is a axial section which is showing decreased tracer uptake in the anterior segment of right lower lobe. Overall impression was segmental and subsegmental mismatched perfusion defect in the right lower lobe and upper lobe suggesting pulmonary thromboembolism. Her USG Doppler bilateral upper limb and lower limb showed biphasic flow in ulnar, radial, popliteal and anterior tibial artery. However, there was no significant restriction of the flow. Her APLA workup was done considering her history of bad obstetric history along with presence of unprovoked DVT and pulmonary thromboembolism, which showed triple positive with lupus anticoagulant titers 1.6, IgG anticardiolipin to 457 and IgG beta to glycoprotein 147. NCS of all four limbs were normal. Skin biopsy from the left sole was done, which showed normal hyperkeratosis and acanthosis. Dermis showed minimal mononuclear infiltrate. These are the direct immunofluorescence images which showed granular IgG deposition in the dermoepidermal junction. Similar immunofluorescence pattern is seen with IgA, IgM and C3. Overall picture fitting into lighthouse effect of SLA. So we made a final diagnosis of SLE involving mucocutaneous involvement in the form of malar rash and livedoid rash, musculoskeletal involvement in the form of polyarthritis, cardiac involvement in the form of severe MR and query myocarditis, hematological involvement in the form of thrombocytopenia, and query lupus nephritis. Even though we don't have renal biopsy, we kept a possibility of lupus nephritis because there are because she is having UPCR of 1.7 and deranged RFT. Along with secondary APS with catastrophic APLA, since she is having triple positive APL antibodies and vascular involvement in the form of organ involvement in the form of vascular thrombosis, APL associated livedoid reticularis, APL associated cardiac valve disease, and APL associated nephropathy. Applying the preliminary criteria for catastrophic APS, our patient is fitting into, our patient has evidence of more than 3 organ involvement, and all the organ manifestations developed within 1 week, and there is laboratory confirmation of presence of antiphospholipid antibodies. So, our case is fitting into probable catastrophic APLA. She was managed in the following lines. IV alprostadil was given in view of pregangrenous changes. UFH was started for pulmonary thromboembolism at the dose of 80 units per kg loading, followed by 18 units per kg per hour with a target APGT of 50 to 90. Followed by she was started on long-term oral anticoagulation with warfarin. For suspicion of active lupus and probable CAPS, she was started on pulse methylprednisolone 1 gram per day for 3 days, followed by oral steroids at 1 milligram per kg per day. She also received cyclophosphamide 750 mg every monthly for 6 months for lupus nephritis. And 5 cycles of Plex was given in every alternate day in view of probable CAPS. My points of discussion are catastrophic APS, organ involvement, pathological mechanisms, diagnostic approach, mimics of CAPS, treatment modalities, and their outcomes. Catastrophic APS was first described in 1992 by Asherson's, so it is also known as Asherson syndrome. The median age of presentation is 37 years with female to male ratio of more than 10:1. The hallmark of the disease is rapid onset multi-organ failure caused by widespread small vessel thrombi. It occurs in less than 1% of patients with APS and has mortality rate of more than 50%. The organ involvement the most commonly involved organ in CAPS is kidney, involving in 71% of the patient. The kidney involvement occurs in the form of TMA, renal artery thrombosis, or renal vein thrombosis. Lung involvement occurs in 64% of patients in the form of pulmonary thromboembolism, pulmonary hypertension, ARDS, and diffuse alveolar hemorrhage. CNS manifestations occurs in 62% of patients, most commonly in the form of sagittal sinus thrombosis and cerebrovascular accident. Skin involvement in the form of livedo reticularis and gangrene, along with skin ulcers. Liver involvement occurs in the form of Budd-Chiari syndrome, liver infarction. Other organ involvement being spleen, adrenal glands, arterial thrombus, pancreas, retina, peripheral nervous system, and bone marrow. While applying preliminary criteria for catastrophic APS, hematological involvement is not considered as separate organ failure. Definitions of organ involvement. APL-associated cardiac valve disease is defined as presence of triple positive APL antibodies along with echocardiac evidence of valvular lesions in the form of valve thickness, thickening of the valve along with or irregular nodules, or regurgitation or stenosis of the mitral and aortic valve, or any combination of the above. APL-associated nephropathy is defined as presence of histopathologic evidence of thrombotic microangiopathy along with presence of APL antibodies. However, before labeling it as APL-associated nephropathy, we have to rule out other causes of chronic renal ischemia like renal vasculitis, thrombotic microangiopathy, hemolytic uremic syndrome, or malignant hypertension. In the background of SLE, we should able to distinguish these manifestations from that of lupus nephritis. APL-associated livedo reticularis is defined as presence of persistent, irreversible, violaceous, mottled pattern of skin on the arms and trunks. It can be in the form of regular unbroken lines, or it can when it is known as livedo reticularis, or it can be irregular with broken lines when it is known as livedo racemosa. Pathological changes are confirmatory but are not needed for the diagnosis of APL-associated livedo reticularis. APL-associated thrombocytopenia is defined as platelet count of less than 1 lakh at least twice, 12 weeks apart, along with presence of APL antibodies. These are the images of livedoid rash. In the first picture, the rash is regularly branching when it is known as livedoid reticularis. In the second picture, there is irregular branching when it is known as livedoid racemosa. Pathophysiological mechanisms are explained in two-hit hypothesis. First hit is presence of APL antibodies. This presence of APL antibodies induces a prothrombotic state. These APL antibodies interact with endothelial cells by binding to the beta-2 glycoprotein linkages on the cell surface and induces pro-inflammatory state. It also binds to the phospholipid binding proteins on the platelet and thereby potentiates platelet aggregation. It upregulates tissue factor expression on the endothelial cells and monocytes, resulting in leukocyte adhesion, cytokine secretion, and PGE2 synthesis. APL also interfere with components of coagulation cascade. Mere presence of APL antibodies is not sufficient for initiating thrombotic and cytokine storm. There should be a presence of second hit. The most common second hit factors were infection, trauma, immobilization, drugs, surgery. These factors result in complement activation, overall finally resulting in the activation of nuclear factor kappa, beta and MAP kinase pathway activation, resulting in the induction of pro-inflammatory and pro-thrombotic phenotype. Diagnostic approach: in a patient with history of APS and APL positivity based on updated Soporos criteria, patient can be classified as definitive CAPS if he has more than 3 organ involvement in less than 3 weeks and evidence of microthrombus. If there is no evidence of microthrombus and more than 3 organ involvement, then the patient will be categorized as probable CAPS. If there is only 2 organ involvement but there is evidence of microthrombus on the biopsy, then also the patient can be classified as probable CAPS. If there is no evidence of microthrombi along with less than 3 organ involvement, then the patient should not be labeled as catastrophic APS. If the patient doesn't have a history of APS in the background and presenting for the first time with more than 3 organ involvement along with persistently positive APL antibodies, we have to look for microthrombus evidence in the biopsy. If there is microthrombus evidence in the biopsy, the patient should be labeled as definitive CAPS if the repeat APL testing after 12 weeks is positive. If there is no evidence of microthrombi biopsy and still the repeat APL testing after 12 weeks is positive, then the patient is labeled as probable CAPS. If there is no evidence of microthrombus on the biopsy and no evidence of positive repeat APL testing, then the patient should not be labeled as CAPS. The mimics of CAPS. The diagnosis of CAPS is difficult since positive APL antibody testing, positive APL antibodies associated with other conditions like infections and anticoagulation. Therefore, APL antibodies can just present as bystanders rather than contributing to the thrombus sometimes. Catastrophic APS shares overlapping features with thrombotic microangiopathies. The differentials include heparin-induced thrombocytopenia, disseminated intravascular coagulation, sepsis, HELP syndrome, and TTP-HUS. Some soft pointers helps in differentiating these conditions from catastrophic APLA, like history of recent heparin exposure and presence of anti-heparin PF4 antibodies in HIT, evidence of infection and malignancy along with very low fibrinogen levels in DIC, evidence of infection and systemic inflammatory response in sepsis, active pregnancy and abnormal liver enzymes in HELP syndrome, anti-ADAM TS13 antibodies along with predominant neurological symptoms in TTP and predominant renal symptoms in predominant renal manifestation in HUS. There is one entity called seronegative CAPS. It is very rare in which patients do not have classical criteria antibodies, but these patients can still be classified as catastrophic APS if they have other 3 criteria. These cases usually have non-criteria antibodies such as IgA and IgA anticardiolipin and anti-beta-2 glycoprotein antibodies, or IgG, IgM phosphatidyl-serine antibodies, and IgG or IgM anti-annexin 5 antibodies. Sometimes CAPS patients transiently become APL negative at the time of thrombosis, probably due to consumption of these APL antibodies, when it is known as transient seronegative CAPS. This is a case report showing transient seronegative catastrophic APS, where the young adult with SLE presented with multi-organ dysfunction. On evaluation, they found to have microthrombus evidence on the biopsy, but the APL antibodies were negative. After treatment, they repeated the antibody profile after 12 weeks, which came out to be positive. Treatment and its rationale. Patients should be started on antibiotics to control the precipitating infection. And if there is any necrotic organ, that should be amputated because these can precipitate prothrombotic state. Anticoagulation anticoagulation for control of thrombotic storm, corticosteroid for rapid control of cytokine storm, immunosuppressants for aggressive control of inflammation, plasma exchange for removal of APL antibodies, and intravenous immunoglobulins to block immune aggravating factors. Triple therapy is considered as treatment of choice in case of catastrophic APS, which includes a combination of anticoagulation, corticosteroids, and plasmapheresis or IVIG. This has been studied in number of trials. This is one of the largest trial involving CAPS registry patients, which showed that triple therapy is associated with higher survival rate in catastrophic APS. They also found that administration of plasma exchange or immunoglobulin in the triple therapy did not show any difference in the outcome of the catastrophic APS. Role of immunosuppressants. Rituximab is most studied immunosuppressant for CAPS. This is the analysis of the CAPS registry patient who received rituximab as a first line or second line. Among the 20 patients who received rituximab, 75% of the patients were recovered from catastrophic APS and 20% of the patients died at the time of events, supporting its role in catastrophic APS. However, it cannot be used as a first line. It can be used only if there is a treatment failure with triple therapy. Other immunosuppressants that are in use, that are under research are eculizumab, cyclophosphamide, and mTOR inhibitors. Regarding long-term anticoagulation, most clinical trials suggest long-term anticoagulation in the survivor of CAPS. However, there are no strong recommendation on the duration of anticoagulation due to its rarity. For long-term anticoagulation, vitamin K antagonists are indicated. This is a case study showing which describes experience in 7 patients with CAPS in whom anticoagulation was discontinued after 6 months of therapy. On an average follow-up of 5.5 years, only 2% developed one episode of recurrent thrombosis, and none of them developed recurrent CAPS. Outcome of CAPS. Despite of its high mortality and morbidity, long-term outcome of CAPS patients who survive the acute event is very good. The recurrence is very rare if the patients are on long-term anticoagulation. Long-term outcomes of survivor and catastrophic APLA in patients with CAPS registry. It showed that 66% of patients who survived initial CAPS were maintained symptom-free along with on anticoagulation on a follow-up of 67.2 months. So the take-home message is CAPS should be considered as a possibility in a patient presenting with rapid onset multi-organ dysfunction after ruling out infection and other common etiologies, and triple therapy should be initiated as early as possible after suspecting the CAPS. Thank you.